Hello. Hello. My name is John Lynch. My partner, Emily Grice, and I interviewed Dr. Wendell Holmes, an orthopedic surgeon, about why he chose to be an orthopedic surgeon, what advice he has for future surgeons, and ulnar collateral ligament reconstruction, also known as Tommy John surgery.
I grew up playing sports and was very active. And by the time I was 19, I'd had knee surgery and a cast on every limb, so I didn't know who my pediatrician was, but I knew who my orthopedic surgeon was. So I identified with them, and then it just ended up when I went to medical school, I kind of knew I wanted to do orthopedics. Make good grades, learn a lot in school. If there are things that interest you, kind of follow your passions. There's a little bit of a road to get into orthopedic surgery. You gotta do well enough in college to get to med school, and and then orthopedic surgery, unfortunately, is a relatively competitive subspecialty. So even after completing medical school, you've had to do well in your class to qualify for an orthopedic residency. So my best advice is make good grades. Don't worry about 8 years from now, right this minute,
So why would someone need Tommy John surgery? If someone is having chronic elbow pain and is unable to warm up, they may have a UCL tear. This happens from repeated stress and overuse, which Dr. Holmes will describe for us on the next slide. If a patient presents with these symptoms, the orthopedic surgeon will do a clinical exam and order an MRI to determine if the UCL is torn.
When I was growing up, I played baseball. I was a good baseball player, but I played for 3 or 4 months a year, maybe a little extra in the summer, and then in fall and winter you played a different sport. Now the baseball players will play 8, 9, 10 months a year, and it's the UCL injury, that Tommy John's injury, is an attritional injury. One of our terms is cumulative microtrauma. You're gradually traumatizing over time, and it's not one throw that tears the UCL, it's the last 1,000 or 10,000 throws that did it.
For the procedure, the patient is positioned in the supine position with the injured arm out. The orthopedic surgeon will then remove the palmaris longus tendon from the forearm. Next, he or she will drill 2 holes in the medial, the inside elbow, and 3 in the ulna, the outside elbow, to weave the palmaris longus tendon in a figure 8 pattern. Then, the surgeon sutures the elbow incision, as we can see here. To prevent infection in the surgery, antibiotics may be prescribed. The surgery is near the ulnar nerve, so neuropathy, pain, numbness, or weakness in the arm is possible. The surgical team consists of an orthopedic surgeon, like Dr. Holmes, an assistant surgeon, a circulator who makes sure the OR is sterile, a scrub nurse who makes sure proper equipment is ready for the surgeon, and an anesthesiologist. The anesthesiologist has to make sure the anesthesia won't react with any of the patient's other medicine, so a thorough history must be done. He or she also monitors the lungs of the patient. All team members must follow national patient safety goals set by the Joint Commission, and they must follow regulations set by the Orthopedic Surgical Manufacturers Association as well. For the surgery, the UCL instrument set has drill bits and guides to drill into the elbow. Forceps are used to remove the palmaris longus and guide the tendon in the figure 8 pattern. A scalpel is needed to make incision, and sutures are needed to close the incision. Retractors are needed to keep the incision open during surgery, as seen in this picture. After surgery, a dressing is applied with a splint that keeps the elbow bent at 90 degrees and the forearm neutral. After 10 days, the splint is replaced with a brace that allows more movement for rehab. The rehab consists of re-strengthening and re-establishing the range of motion. For someone to get back to a competitive level after UCL reconstruction, the rehab takes 12 to 15 months.